respected dignitaries on and off the dais, and particularly family members of Dr. Chitra Gopal, Mr. Balagopal, Mr. Mohan Gopal, and other family members. It's indeed an honor and a privilege, to stand before you all today when we are recognizing and remembering the life of such an inspirational woman. And we saw from that video, the passion and the commitment with which Dr. Chitra lived her life, and the example that she gave of, noticing a problem of these young women who were coming in and dying unnecessarily because they didn't have the access to proper midwifery services during their delivery time, and how she went about solving that problem, I think is a great example for each and every one of us, but particularly for the young people today, because very often when we see a problem, we tend to either not go deeper into it, or quite often to believe that the problem is too large and too huge to be solved. And this, of course, is a challenge in a country like India, where everything, you have to multiply by 1.4 billion people. So any challenge always becomes a very large one. But at the same time, I think examples like this, and from the lives of other people who have lived here, in India, and have solved some of our major challenges that we faced, whether it was food security or whether it was issues of high maternal mortality, that when there is one person who wants to make a difference, it can actually happen. And I think it was Margaret Mead who said, and I'm paraphrasing, that it doesn't need a huge crowd of people to change something in the world. In fact, most things that change in the world are usually because there is a small group of people who are committed to the cause and who keep on at it till something is changed. So we can think of many examples, I think, in my own 40 years of 1982 is when I entered my MD at the All India Institute of Medical Sciences, and one of the most frequent admissions we would have on the ward was neonatal tetanus. It's the most horrible thing to see, and Dr. MKC and others, pediatricians, senior ones would have seen it. Luckily, none of the juniors, none of you have seen neonatal tetanus. But from the other end of the ward, as the mother and baby, and they used to come from all over North India to the All India Institute of Medical Sciences, traveling for hundreds of kilometers with this small baby, 6-7 days old, because of the practice of applying cow dung onto the umbilical cord. And you could see from a distance that from the facial expression, you could diagnose neonatal tetanus. You didn't even need to do any more investigations, and it was a very high fatality disease. So to think that within 20-25 years, actually, India eliminated neonatal tetanus. All of us have seen poliomyelitis. We all have relatives probably who have poliomyelitis. We have eliminated that. Of course, globally, we have only one disease that got eradicated, that is smallpox. And we heard from Dr. Vijay Raghavan also, who gave an amazing tribute to Dr. Chitra Gopal, that we could understand much better her personality, her commitment to teaching. And the way she went about it was actually learning by seeing and learning by doing, rather than sitting in lecture halls listening to lectures. So I think there is nothing to replace that, really. So in fact, that's one of the things I try to do when I travel somewhere, is to always visit the community and talk to the community, because in my career I have realized that some of the insights that you get from the community you cannot get from anywhere else or from any book. And of course, I've spent most of my career doing research on tuberculosis and HIV, and even the way that I got into HIV was because I worked at the Tuberculosis Research Center in Chennai, and it was very obvious that TB was actually the one infection that was killing most of the HIV infected people in India, but also in sub-Saharan Africa, that there was need for a lot more research on how to diagnose, how to prevent, how to treat HIV-associated TB. And remember, this was before antiretroviral treatment, and there was so much of fear and stigma associated with the disease that very few doctors and health professionals actually wanted to deal with people who had HIV infection, because it was a fatal illness. With sooner or later you were going to progress and die. And so naturally, as human beings, everybody has that fear. So I remember at that time, my boss, the Director General of the ICMR, had come to Chennai, and he said to me, "You should start work on HIV and TB." And I said, I'll be happy to do that. We already have an AIDS Research Institute in Pune. Will there be some confusion? And he said, "No, there's enough work to be done. You focus on TB, HIV. Nobody in India is working on that right now." So I think that was the best advice I had in my career, because it was a new area. It was challenging. So I went around asking, we have about 500 staff in the institute, who's going to join me in this new program that we're setting up. There were exactly 5 people who were willing to work with me, again, because it was HIV. And in fact, we were really looked upon as a little outlier team. People used to look at us a little bit differently, and we were always asked to be washing our hands when we came back from the hospital. And at that time, Dr. Devanayagam was in Tambaram Hospital, and Tambaram became very famous. It was a sanatorium originally set up by the British for TB, and then it continued as a chest and thoracic diseases hospital. There used to be thoracic surgeries performed there. But Dr. Devanayagam, again an FRCP trained, very nationalistic, patriotic physician and an excellent teacher, was at that time the superintendent, and he said, "I will take care of all HIV infected people." So the whole of South India, actually, we used to have people pouring into that sanatorium, and it became an HIV hospital, but in a way it was a real learning ground for many generations of doctors, because it was not something anybody had seen before. But then I also saw the social side of disease, and as again reminded by Dr. Chitra Gopal's, the way she described her approach, not only just training midwives and then expecting them to do their work, but actually looking at the social circumstances in which these girls had to work, and ensuring that they were taken care of so that they could perform their services, going to the panchayats, talking to the panchayat leaders. So we had to do a lot of that, because we found that these people who, young men and women, because most of them were in their 20s and 30s, and in some the disease would progress faster than in others, but invariably the story was the man would be infected first, and of course, as you know, truck drivers in the beginning was a group that was highly impacted by this epidemic, but there were other professions as well, would infect his wife, and sometimes, maternal to child transmission, the children would be also born with HIV, and the man would progress and die first, and then the women and children were left usually without any social support, because they were thrown out of their homes in most cases. So we had to deal with the social and the legal and all of these other aspects, psychological trauma. And I can never forget a patient saying to me, he was dying. It was very clear that he was dying, and we would go on morning rounds, and I would make sure that we talked to every patient. And so I went to his bedside, and I was holding his hand and, talking to him. And he said, I know that you've done everything possible for me, and there's nothing more that you can do. You've taken very good care. Your team has, taken care of me. And it was actually a bit sad, because the patients that we took care of, the research group, were actually much, much better taken care of than the other patients in the ward, because in a busy hospital with hundreds of patients, you know how it is in a general ward. But these research patients, we would, so they were more privileged compared to the others, but still they were dying. And so he said, the fact that you come and you hold my hand and talk to me is more than makes up for the fact that you cannot treat me or cure me, because the stigma is more of a killer than the actual medical process that was going on. And so these lessons that I learned from patients with tuberculosis, who come from the poorest sections of society, and who are very often facing so many challenges in their life. And as doctors, sometimes you're sitting in the clinic and advising people, do this, do that, eat this, eat that, don't, take rest or don't smoke. And then you visited, we used to do home visits because very often these TB patients would not come for treatment, and so we would go home to find out, and then you see the actual situation, how that patient is living and how the family is coping, and then you have a very different approach to dealing with this. So I think I very much relate to what was said about Dr. Chitra and also what we saw in her video clip. And I hope that element of empathy and compassion that is part of the medical profession and public health should stay. Because with more and more automation coming, more and more computers and databases, sometimes there's a tendency for us to maybe drift away. And so nothing can replace the human touch in the medical profession. So I think that in the health profession as a whole, I wouldn't say that. In fact, nurses are much closer to patients than doctors are. And I personally have learned a lot from the nurses that I worked with. The other lesson that from that early time of working with HIV, which I saw again repeated during the COVID pandemic, was of course the issues of equity and social justice to some extent. Equity because once antiretrovirals were developed and had become available in the Western countries, high-income countries, by the late 1990s, but were not yet available in the most of developing world, patients used to ask that question as to why they could not get the drugs. If drugs had been discovered and were available in some part of the world, why is it that they were not available here to them? And wasn't their life, equally valuable as the life of somebody? And we had no answer to that question. So when I saw that being repeated again during the pandemic, where it was mentioned about COVAX. COVAX was the initiative that we set up essentially to address the issue of global inequity, because we had predicted that this could happen, that vaccines may be developed. We didn't know whether we would have successful vaccines or not. There are many viral diseases for which there are no vaccines. And so when COVID hit, it was anybody's guess whether a vaccine would be developed, but of course there was huge amount of effort made, and we were lucky to have not one or two, but dozens of safe and effective vaccines. But we knew that in the beginning that there would be shortage of vaccines because no company would be able to make billions of doses overnight. And so we had gone through a process of what we called an equitable allocation framework, where we said, okay, if you have a limited supply, how would you distribute it around the world to protect the maximum number of people and save the most lives? And it was clear by then that the people who were at risk were the older people, people who have underlying comorbidities, and of course frontline workers, health workers, who were already dying by then, and it was clear that they were at very high risk. So if you took only these categories of people, it comes to something like 10%, not more than 10% of an average country's population. In a high-income country, yes, older people are a slightly higher number. But overall, if you take an average globally, we could have, if we had distributed the vaccines that we had equitably, not equally, but equitably, and there is a difference between equality and equity that sometimes is not clear. The example I like to give is if there is a tree with the apples growing on it, right, and you have a number of children of different heights standing under that apple tree trying to pluck apples. If you put everybody on a stool of the same height, right, that's equality. You're giving everybody exactly the same additional help. And so they all stand on that stool. The taller children get taller. The shorter children will still not be able to reach the apple tree. So the taller ones get the advantage and they can take the apples. Equity is if you give stools of different heights to the different children, and you give the shorter children a higher stool, and then everybody has an equal chance of plucking the apples. So that is a difference between equality and equity. And equity means that you have to address the ones that are the worse off. And I think it's very important for us when we talk about public health today, particularly in a state like Kerala, which is extremely advanced in its healthcare. And we heard, the fantastic, if you look at the indicators and maternal and child mortality and so on, unbeatable record. The issues of equity and social justice actually become much more important, because even in the most advanced countries, the most high-income countries of the world, which have all the technologies and everything available to them, we saw that the people most impacted and the highest death rates were among those who were at the bottom of the socioeconomic pyramid. And you saw the African Americans having 2 to 3 times higher risk of infection and death. In the UK, you saw that it was the Asian immigrant community that was impacted much more. And nobody could really explain, but there were a variety of factors which related both to their poverty and the housing and the large families they lived in, to the occupations where they could not isolate at home. Some people were privileged, they could work from home. These people had to go to work. They were mostly frontline workers, and therefore they were exposed more, infected more. And then they also had underlying comorbidities, higher rates of obesity, for example, amongst the African Americans than among white Americans, and so on. So I think in every country these exist already. And if you look at our own NFHS data and analyze by socioeconomic status or by caste status, you will find that the SC and ST communities have several percentage points lower indicators in any indicator you take, whether it's infant mortality or whether it's nutrition or anemia or anything related to education. So we have to address that. And so coming back to the COVID situation and COVAX, I would say partially successful, because what happened is that the countries who had the resources had pre-booked at risk. They had already placed orders with many different vaccine companies because nobody knew which company was going to succeed. And so they had put billions of dollars already into blocking the first doses of the vaccine coming out. And so those countries had access to many different vaccines. Countries like India and China, which have their own manufacturing capacity, had also access to vaccines. But all the other countries that either didn't have the resources or didn't have manufacturing capacity, like, for example, the entire continent of Africa was dependent really on COVAX for access to vaccines. And I still remember those days in mid-2021 when, of course, the first vaccines were rolled out in December 2020, if you remember. And by early 21, many countries had started their vaccination programs. COVAX was also depending on Indian manufacturers like the Serum Institute to provide vaccines. And of course, India needed also the vaccines at the same time. So the lesson from all of that was that health is too important to be addressed through donations or through philanthropy alone. And that countries, of course, then the African Union decided that they cannot be in this situation anymore. So they actually got together, the Africa CDC, which was a new organization, then developed their plan, and now they have a roadmap for how they are going to develop their own health technologies. So when I witnessed that, I found that the solution was not to keep on criticizing the high-income countries, because you can keep doing that, but it's not going to change anything. And of course, we were doing that as WHO, but to really do something very practical. And that's how we started the mRNA technology transfer program, where we said, here's a new technology, very successful, but it's in the hands of only few top multinational companies, which were refusing to share that technology. If you remember, India and South Africa had gone to the World Trade Organization early in 2020 and said there should be a waiver of the TRIPS. The IP waiver should be brought in so that any diagnostic or treatment or vaccines developed for COVID must be made open access. And of course, it was blocked at the WTO by the same countries where these big companies are hosted. And so we decided that we need another model, and that model is of open science, where basically scientists are given the tools, the knowledge, because a lot of knowledge is now available in the public domain, and you can use that to create the same products. So we called it democratization, really, of knowledge, and we asked countries to put in applications. We received a lot, but South Africa was then selected as the hub for this mRNA tech transfer program, and I'm really happy today to see that not only were they able to create a mRNA vaccine from scratch. It was basically the same Moderna vaccine, but they did it from scratch without any help from Moderna. But now there's a network of 16 centers, 16 countries that are part of this mRNA tech transfer program, where I hope what we will see in the future is collaboration in research, in manufacturing, so that not only COVID vaccines, because actually there's no need now to make more COVID vaccines, so that product is being developed more as a proof of principle that it can be done, but diseases like dengue, diseases like tuberculosis, HIV, malaria, for which we still need vaccines, chikungunya, there are any number of infections for which we don't have good vaccines, needs to be, can be developed by this network. And the best part is that if you can develop a prototype vaccine for a number of families of viruses, there are about 25 or 27 families of viruses that can potentially cause epidemics and pandemics. So I think for India also we need a similar roadmap, like what we developed for the world and what we developed for Africa. A roadmap where we look at our public health challenges and or let's say the important infectious diseases that we have. But the good thing about mRNA technology is not just for infectious diseases, not only for vaccines, but you can use it to make monoclonal antibodies for cancer and so on. And India has the capacity to do it affordably. So to go back to HIV, it was Yusuf Hamid in Cipla who took on this challenge of making affordable antiretroviral treatments. And because of, I would say that, because of him and people like him in India, that today there are 35 or 36 million people around the world on antiretroviral treatment. He brought the price down from, at that time, $10,000 a year is what the big companies were selling it for, and he brought it to $1 a day. And it's even cheaper now, and of course there are much better combinations. But he did it before the IP rules changed in 2005. It's much more difficult today for Indian companies to break that type of IP and patent. So this is what we see in TB today. Bedaquiline, J&J had filed for extension of their patent, which was expiring this year. Bedaquiline is a drug that's used for MDR TB treatment. 2 young MDR TB survivors, one of them from India, one from South Africa, went to the court in India, and the court threw out the application of J&J, so that now bedaquiline the patent will expire later this year, and Indian companies and any other companies will be able to make it. So the lesson around all this is that sometimes as medical people, we think that these health products, vaccines, drugs, which are life-saving, should be public goods. But the current model of R&D, which is driven by profits in the most instances, looks at these health products very differently. So I think being self-sufficient is important, and India, of course, is in a position to help other countries as well because the expertise we have. But again, for ourselves, I think we need to think about cancer treatment, treatment for rare diseases, things for which so far we have not done a lot of innovation. A lot of the innovation has been happening somewhere else, and then we are able to make that product at a lower cost. We need to be doing more innovation, and we need to be doing it in the areas which are affecting our populations. Diabetes, hypertension, cancer, dementia, these are all going to increase in the future, and we cannot rely on imported technology. Similarly, assistive devices, which every older person needs. And I think Kerala is one of the states which is already having a very high life expectancy, many more older people. This is a good thing, but it can only be a good thing if those people live a good quality of life. And so I think thinking about what older people are going to need in terms of health technologies, of course, like assistive devices. And again, there's a lot of innovation in India today where affordable devices, whether they are hearing aids, even spectacles, and wheelchairs and walking sticks and so on. There's a huge global need, actually, unmet need. And so India can I think, fill that gap, not only for our own population, but there's a big demand out there as well. The talk is about public health, but I was, maybe digressed a little bit into some of the lessons from the pandemic, but clearly the lessons that we learned by looking globally at the response to the pandemic was that those countries which had invested in public health and primary health care in particular did the best in terms of the lowest amount of infection and the lowest amount of death. And they were not necessarily the high-income countries, but these were countries like Thailand, like Vietnam, like Rwanda, like Senegal, of course Bhutan in our own region, where they firstly recognized the problem early on. They had a strong public health cadre, and they listened to the advice of the public health people. And the most important was that they had primary health care with involvement of communities. And that community engagement and the trust which the health system had built with the community proved to be the key element of, because you needed behavior change, right, as a response in this pandemic. Early on, you needed the social distancing, the masking, and those kind of things, which were all very new and difficult for people to follow. And later on, of course, you needed people to take their vaccines. All of that is behavior. And if you have a trusted relationship between the health system and the community, it clearly was much more effective. And studies have shown that those countries where there was high level of trust between people in the community, as well as trust between people and governments, those countries, and the Scandinavian countries actually stood out, had the lowest infections as well as the lowest mortality per capita, per 100 people. So two big things: investing in science and research, and investing in public health, which is often very difficult to do politically, because public health functions are always behind the scenes. They're invisible. And to convince politicians to invest into those functions requires a lot of clarity, a lot of persuasion, and a good plan to take forward. But I think luckily, maybe the silver lining from the pandemic is the recognition by the world at large, one about the manufacturing, the R&D. So countries in Africa today know that they need to plan to become self-reliant. If not every country, then at least at a regional level, they will make that effort. And every country today recognizes, and including the CDC in the US, which did a very good review and came out, they acknowledged all of the failures and mistakes, which basically are related to the fact that the CDC at the center has no power or connection with the state public health. So every state in the US, independent public health authority, they need not share the data. They may or they may not, or they could share it by delayed. They don't have to follow the recommendations of the national CDC. So when you're dealing with an emergency, you cannot have a situation in a large country where every state is doing its own thing. So they have recognized that not only was the investment in public health going down over the years, but that this relationship between center and states in terms of public health action was fragmented, and they need to bring it back. They need a new law which will allow this to happen in a much more efficient manner. So I think it's very good for countries to look back for states, for large countries like India, the states could do that kind of review of the last 3 years, what went well, and a lot of things were done well. Maybe what did not go so well, which today we can look back and really look at the reasons why, what are the gaps, and how do we fill those gaps for the future, because certainly this pandemic is not the last pandemic. Let us hope that doesn't happen again in the near future, but one can never tell when the next zoonotic infection is going to jump from an animal or a bird to a human. We've seen avian influenza today around the world is spreading quite worryingly across many species of birds, both wild and domestic. And it's a matter of a few mutations before it becomes transmissible. It does occasionally transmit to humans, but so far it's not transmitting human to human, right? So once that human to human transmission occurs, then of course avian influenza pandemic would be extremely bad. So we need to think about the root causes of this. And again, the public health today in the 21st century has to think much more broadly than focusing only on healthcare delivery and the traditional public health services of water and sanitation and vector control and making sure that systems are operating, etc. Even things like entomology actually is important, and I think we need to see, do we have enough public health entomologists in our public health programs? Because vector-borne diseases are going to be important, they already are, and they're going to change in nature, and they're going to change their geographies as with climate change. And unexpected vector-borne diseases, like we have scrub typhus in India, large number of scrub typhus cases are not recognized, not diagnosed, not treated, and could end up dying. I remember going to Gorakhpur. Year after year, there used to be this outbreak, which was just known as an encephalitis outbreak. And eventually, by doing the genomic studies, we found that a lot of them were because of scrub typhus, and a simple treatment actually can deal with this infection, and these children don't need to die. So the deaths today have gone down dramatically, but that's because the diagnosis and treatment of scrub typhus was scaled up. So I think we need to use new technologies like gene sequencing that we have today. We've used it for COVID. We need to think where else in public health, and an outbreak of an unknown disease is obviously a very obvious example where you would want to use whole genome sequencing or metagenomics, as it's called, to try to identify what the pathogen is. So building that capacity at the state level, but then going down at the to the district, but also much below the district level, because ultimately epidemics begin and end in communities. They don't just happen somewhere. It's always some community which will have the first case. And if you have a cadre of people who are trained to recognize and pick up something that's going unusual happening, and they are able to report quickly, investigate, use technologies, the data collection mechanisms need to be good, and there needs to be authority also given at that level to people to take action. So decentralization is extremely important in terms of building the capacity and also the ability to take action immediately, because I think the question is going to be next time is how quickly can we limit it? Can we limit and prevent an outbreak or epidemic from becoming much bigger or becoming a pandemic? And I think Kerala did extremely well with the Nipah infection on both occasions. But with an airborne virus, with an airborne pathogen, it's much more difficult than with a pathogen which is blood-borne or through body secretions, because that's why SARS-1 and SARS-2 were so different, because SARS-1 was much more spread, person to person, droplets, and also people presented, they all got sick. So you didn't have asymptomatic spread. And so the moment somebody had symptoms, you could isolate them, do the contact tracing, isolate all the contacts, and that's how in 8 months SARS-1 was actually controlled, even though it had spread around the world and it was in many countries. SARS-2, we found out later that there was asymptomatic spread and that not everybody had symptoms. and also that it was aerosolized and it could infect people in the same room, even if you're not very close to the next person. So these things we learnt over the months of 2020, and therefore the advisories and responses also kept changing. So we have to look at what are the essential public health functions that are needed. And that really needs to be, the principle really needs to be that it has to be based on the needs of the population. So one needs to constantly have a mechanism and a surveillance so that you know you're monitoring and evaluating the population's health status, whether it is through surveys like NFHS or other kinds of surveillance, and also looking at the risk factors to health and paying attention to those. We need a whole focus on how an emergencies will be managed. There needs to be attention to the governance, to the regulations and the legislation, and I think probably some of our laws which are outdated really need to be revised as to how the disasters will be dealt with. And when we think about public health, we shouldn't think only about infectious diseases or non-communicable diseases, but we also now need to think about not only biological threats, but chemical, nuclear, so all types of threats which could come to the population. And then you need always, for public health, a multi-sectoral planning. And the reason is that many of the threats to health are not within really the domain of the health ministry, but would lie outside. As an example, road traffic accidents, right, which is a leading cause, and in fact, it's increasing. If you look at developing countries versus developed countries, there the road traffic accidents are on the decline, and in the developed world, with more and more traffic, it's increasing. So road traffic accidents is one example. Another one is air pollution, which of course impacts, as we know, all our organ systems. Another example is our diets. What do we eat? The whole food system. What do we get as subsidized food? What are we able to buy and eat? Why are we eating these things? The whole shift of diets from something that used to be healthy, homemade, from locally available, more of fruits, vegetables, millets, coarse cereals. The whole thing has now shifted to refined carbohydrates, high sugar, high salt, high fat diets. And that is what is driving all of our non-communicable diseases, which are all going up. And so physical inactivity is another risk factor for non-communicable diseases, and of course tobacco and alcohol. Mental health is the other major non-communicable disease. So between injuries and road traffic injuries and these risk factors for non-communicable diseases, you have a range of public health problems, large ones, where the solutions lie outside the health sector. And that is why health has to be elevated, even at the political level, and it did get elevated during the pandemic, but we hope that that can continue, because it is very clear that without good health, you cannot have economic progress. And so if you want to dream of being economically doing much, much better in the future, I think a prerequisite for that is to have a healthy population, which includes good nutrition, especially for pregnant women and young children, because of the brain development of the child being impacted, and that affects cognitive development. And so it's a question of human capital. If we want to really make use of the demographic dividend, and as you know, we are all talking today about India becoming the most populous country in the world, but also saying that we have a young population, that we have the demographic dividend. Well, I think Kerala is already in that demographic transition, which the whole of India is going to be in a few decades. But for the next few decades, yes, we will have that advantage, but only if our young people are well nourished, they have good brain development, and also, of course, good education and skilling, in which case they can be highly productive members of society. So I think the point is to think about the risk factors for health, not just the downstream. What do we do when people get sick? We set up more cardiac care centers, more dialysis centers. There will be no end to that, actually, if we're not turning off the tap at the other end. So this is why we today talk more about health promotion and disease prevention being really important. And that, again, is something that people teach in community medicine. And PSM was always about that, but most of us paid no attention to that because obviously the clinical aspects of medicine are always much more exciting and interesting rather than thinking that's very boring, let somebody else think about prevention. But unfortunately, the more you see about health and the more you understand, you'll realize that that actually probably is the most critical. Community engagement, participation, and social mobilization are extremely important. And we saw that again during the pandemic, that there was a mobilization of a different kind, and that was misinformation. And this was very shocking to me, that there could be so much of misinformation and anti-science and anti-vaccine activities going on when you would expect that most people would welcome the new tools, the vaccines that got us out of the pandemic. But even before there were vaccines available, the anti-vax group had already started their misinformation campaigns, even before. And of course, once there were vaccines available, they used to feed a lot of half-truths, actually. So the most clever misinformation is, or disinformation, is always when there is a very small grain of truth, and then you take that and you distort it. You take some figure from somewhere, which is actually a scientific paper, but then distort it and change the interpretation so that it becomes a very scary. And I saw that a lot with vaccine side effects, because yes, all countries were asked to report vaccine side effects. It's important. Pharmacovigilance is important, because especially when you're dealing with a new vaccine and a new disease, and when hundreds of millions, billions of people are getting it, you need to keep on studying the safety of these vaccines. So there were reports that there were these, clotting defects happening with the viral vectored vaccines, that there were rare cases of myocarditis in young men with the mRNA vaccines, but they were 4 or 5 cases per million. So the benefit risk of the vaccines was still extremely high. It was extremely positive, the benefit risk ratio. But the anti-vax group would pick those couple of cases and then distort all the numbers, and without any denominators and make very scary videos, etc. So misinformation and disinformation is here to stay. Social media is here to stay. We've all, I'm sure, experienced it. And I met somebody from Africa, from a country in Africa, who told me that there in that country, it's a small West African French-speaking country, that their population relies on WhatsApp to get health information. They do not rely on the government. They do not believe what the government is telling them, and so they rely only on WhatsApp. So you can imagine that if these videos can go around on WhatsApp, what impact that would have on the population. And sometimes, quite often, these videos are coming from outside the country, but then they get circulated. So public health to diagnostics, so that we stop the overuse of antibiotics, and we are actually diagnosing and treating what people have. And I gave the example of scrub typhus, which without a diagnostic test, you will not be able to make the diagnosis. So I think having essential medicines list, essential diagnostics list, essential list of health technologies is going to be important. And finally, research. So research is what actually helps you to improve what you're doing. You can call it monitoring and evaluation, you can call it impact evaluation, you can call it implementation research. So this is not research which is happening in labs I'm talking about, but I'm talking about public health research, which addresses also some of the social issues, economic issues, the barriers that people have, looking at gender issues, looking at issues of access, of equity. All these can be actually addressed by research, which could be just looking at secondary data, analyzing it. We do a lot of data collection in our country. We also need to be able to use that data to make policy decisions in a much more real-time way. So I think that cooperation between academia and public health is also very important, and we need to encourage much more of that. And I hope that the Kerala University of Health Sciences will take a lead really in the interest and passion for research in medical students by exposing them to research during undergraduate. The way that I got interested in research was as a school student, as a science talent scholar. I spent one summer holiday in a lab in Calcutta with a very famous geneticist, human geneticist called Professor Archana Sharma. That was for my science talent project. And my project was to, she took me to the clinic, the genetics clinic in the Medical College Hospital, where I saw a young girl with Turner's syndrome, maybe 1 or 2 years older than I was at that time, and she had been brought in. Those who are doctors will know that Turner syndrome is a chromosomal abnormality, but the second X chromosome is missing. And so the girl never attains her puberty or secondary sexual characteristics. So she was brought there, and we drew blood, and we went back to the lab, and then I was given the task of karyotyping and producing her, the pattern of chromosomes. And it was the most exciting moment for me when I did the karyotyping. Of course, I was helped by people in the lab, but I had to do it myself, and saw that this girl had only one X chromosome. And that really kindled for me, I must have been, 14 or 15 years old, the passion for research. And for a long time, I wanted to be a geneticist. But I think the exposure during school and college years to research will definitely get more people interested and wanting to take up research. And there are so many different kinds of research that are possible to do. You don't have to be in a highly endowed research institute to do research. I know excellent public health researchers in our country who have done research in the most remote tribal areas. Abhay and Rani Bang are a good example of a couple that have made massive changes to policy and saved lots of lives by doing research, but in a highly tribal area. And there are many more examples like that of people in private practice also who have really contributed to our understanding of disease. So research, many people think you need a big, huge team, you need basically good data collection. You need to understand the problem. Of course, you need to ask a good research question and then use the data to address that. So I think that we also going to have another challenge of how we are going to use artificial intelligence. Digital technologies, yes, I think they've been a game changer, and we saw telemedicine, telehealth really take off during the pandemic, and many other digital applications. So I think those things should be here to stay. They should be expanded. There should be more innovation in the way that they are used, made more effective, especially for outreach. And that is there. But the use of artificial intelligence also offers lots of opportunities, but there are also some risks. And I think that what we need is a careful look at what the technology is, what problem is it trying to solve, and do we need it firstly. Now, blindly, we should not be thinking that every problem, the solution is technology. But very often technology can help. It can be complementary to what the healthcare workers are doing. For example, I was traveling in Orissa in a remote place, and the CHO there in the sub-center, in the Health and Wellness Center, she not only had the basic drugs, etc., and she could take care of patients, but she was regularly connecting with the doctors at the CHC or at the district hospital whenever she needed a specialist consultation, and it was happening on a regular basis. So patients who came to that Health and Wellness Center actually got a consultation with a specialist. And so that kind of thing, I think really took off during the pandemic, and it's definitely should be strengthened and expanded further. There could be applications of AI in things like X-ray reading, for example, if we want to do X-ray screening of large populations for TB. AI could help us. There are many validated AI algorithms. Similarly, there are applications for cervical cancer screening, also for reading of pathology slides where there are, there's a lack of pathologists and so on. So there are many applications where AI could be a very good tool to improve our healthcare delivery, but ultimately we have to keep an eye on health outcomes and think, is this new technology helping us to achieve better health outcomes? Just like Dr. Chitra Gopal, the goal was to reduce maternal mortality, and so what she did, the intervention, of training midwives, ultimately, if it had not resulted in that reduction in maternal mortality, then probably they would have had to go back and think, okay, what went wrong in that? What was a missing ingredient? So the health outcome is important, and so technology can help us, but again, that needs people who are looking at those outcomes. So it needs researchers, and it needs statisticians and data scientists. So that whole area also of public health, probably that we need to strengthen further, the whole thing of data science, being able to link different databases. Today we talk about big data, etc., but you need people who understand how to use those data sets and to do the analysis. And ultimately, it's about One Health, and I'm happy that Kerala seems to be quite planning to take a lead in that and set up a center of excellence for One Health. It is going to be in the future about One Health, the environment, the whole animal kingdom, and human beings will need to live in harmony if we're going to combat the big challenges that are going to face us in the future, including climate change, antimicrobial resistance, and of course the threat of future pandemics. So I hope I haven't depressed all of you too much by what I've said, but I've just tried to look ahead a little bit, but also take inspiration from the past and not be dejected that we cannot solve some of the problems that we have today, even though they seem very, very large. I mean, the problem of obesity and diabetes for me today is one of the biggest challenges we have. But there are examples of countries that have reversed it by taking the right public policies. So what we need is the combination of public health and good policy makers who can come together and bring those right public policy levers in place, actually to help people to live a healthier life. Thank you very much. Yeah, thank you.